Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Arginex.
Off-label therapies have not been approved for the use specified in this activity. This information should not be considered as a recommendation for the use of a drug outside of the recommendations in the currently approved prescribing information.
This program is presented by Medscape Education Global.
Hello, I'm Heinz Windel, Professor of Neurology at the University of Freiburg in Freiburg, South Germany. So welcome to this program titled Myasthenia Gravis Guidelines, a Global View for Local Practice. Joining me today are Amelia Evoli. She's Associate Professor of Neurology at the Catholic University in Rome, Italy. Niels Gilhus, Professor of Neurology at the University of Bergen in Norway. And Ali Al-Sheri, Associate Professor of Neurology and Neuromuscular at Al Faisal University in Riyadh, Saudi Arabia. Welcome, dear colleagues and friends, to this activity. So why are we covering this topic today? National guidelines for the management of myasthenia gravis are available in different countries. That's quite obvious. With the advent of novel targeted therapies, and that has happened a lot, understanding how to implement these guidelines to achieve patient goals and to improve disease control is obviously key to the appropriate management of MG. So let's briefly introduce the overarching goals for each local guideline and when were these published. So we're having obviously Italy, Nordics, International, Middle East, and Germany. Maybe we're starting with Middle East. Ali.
Okay, well, thank you so much, Heinz. The GCC guidelines was established because of the significant and remarkable, therapeutic or advancement in the therapeutic, management of myasthenia gravis. We know the international guidance provides an excellent scientific framework. However, implementation of those, international guidance might be difficult in certain regions. So in our region, our clinician, they face unique healthcare, requirement. Reimbursement pathway is a bit different, and cultural consideration and expectation are different. That's why we thought, developing a local practical guidelines that would help our clinician to navigate through the new advancement in the field is necessary.
Thanks. Niels, maybe you take the view on Nordics and the international consensus guidelines.
Yes. The Nordic guidelines was an initiative from neurologists and patient organizations in the 5 Nordic countries to update recommendations regarding treatment. And they are relatively new, whereas the international consensus guidance was an initiative from North America, the American Association, but also with representation from Europe. It was 15 experts originally in 2016, and then it was an update in 2021 on new relevant topics.
Very good. So, Amelia, the Italian ones, very recently updated.
Thank you. Our first recommendations for the management of myasthenia gravis were published in 2019. So with the introduction and the myasthenia gravis therapy of new target therapies, we felt that this recommendation should be updated. And we included in our new recommendations also new diagnostic tools, particularly new assay and serological diagnosis that proved effective in reducing the number of seronegative MG patients. And of course, we focused mostly on targeted therapies, supporting their evidence based integration in the care of myasthenia gravis within our country health system.
Thanks. So I'm finishing being responsible for the German-speaking guidelines that were among the really first ones that adopted this novel approved biologicals in 2023, with exactly trying to not only update but also to really renovate how we think about treatment goals, not only just integrating the new approved therapies, but really uh, thinking very thoroughly how do we manage this disease conceptually, integrating these novel opportunities. Country by country, there are additional ones. Spain has provided a consensus recommendation, Belgium. So this is, I think, a pretty relevant and important project and process. And as you all said, there are country-specific considerations that justify that each country possibly has own guidelines. So when we now have a deeper look, they inform about how to initiate novel therapies, when and how. How do these address patient-centered goals? How does each guideline inform about local practice, and what are the most important recommendations for each guideline? So a quick run through these guidelines, and maybe again, let's start with Niels.
Yeah, I can say a few words about international consensus guidelines published in 2021. And I think a main thing of these regarding these guidelines is a focus on active treatment, that we should be ambitious in treatment. That comes also in, of course, in the later guidelines, but especially in the update 2021, I think it was a stronger focus on ambitious aims and also to define the measurements for improvement using MGADL QMG, that's both patient-reported outcomes and measured outcomes by the neurologist, including also quality of life. So key recommendations include this early active treatment, ambitious treatment. Then we have the Nordic guidance treatment. They are in the same line, ambitious regarding treatment, patient-centered goals. I mentioned initially the strong patient representation in the author group. And we also advocated early rituximab treatment as an alternative in these guidelines. Other key recommendations, and especially regarding new biologic drugs, is that when conventional therapy fails, after long-term specialist follow-up, you should add this drug if they are available in your country. And also we had a focus on thymectomy in this guidance, both in the international consensus guidelines and in the Nordic guidelines, where we strongly advocate thymectomy for generalized myasthenia gravis in early onset, that's before age 50 years, whereas it should be considered up to age 65 years and also might be considered in ocular myasthenia gravis and also probably in children.
Thanks very much. So I'm continuing with the German guidelines. We innovated in several ways and focused on one thing which I think is important. So we focused on letting therapeutic decisions being guided by the assessment of activity in a certain state, differentiating the disease presenting as mild moderate as opposed to active or highly active. And we also integrated the let's say the presentation or the phenotype of refractory MG in being highly active. So we do not separate this as a distinct call it phenotype or description. In addition to that, we then adopted what treatment options are available in each of these categories, and then building a class of complement inhibitors and a class of FcRn modulators to be applicable and useful in the treatment of active or highly active or refractory MG, allowing really earlier integration of these novel biological therapies into therapy. And similar to the mentioned guidelines, international and Nordic, we have a strong focus also on the fact that quantitative outcome measures should be integrated, things like MG-ADL, plus also a focus on sparing steroids. We're coming to this aspect certainly later. Maybe we move to you, Ali, the Saudi Middle East consensus guidelines.
Yeah. Well, I think we have a very unique population, not unique from disease point of view, but if you look to the prevalence of cardiometabolic comorbidities, our region considered to be the highest when it comes to the obesity, to diabetes, and other metabolic syndromes. And that's why, for the first time, we emphasize on the importance of looking to the steroid as, a disease burden rather than, just a treatment side effect. And that's why we emphasize the importance of optimizing the non-steroidal immunosuppressant from the early onset of the disease, and considering when you have unsatisfactory response or untolerable side effect or aggressive disease, immediate or early adaptation of the new targeted and precision treatment, like complement and FcR inhibitor, as well as the B depletion therapy. For the first time, we start, introducing the patient-reported outcome, so MG-ADL and quality of life improvement, considered to be mandatory when you are managing those patients to guide you throughout, the treatment journey. And the aim is fewer exacerbation, hospitalization, as well as minimum corticosteroid, side effect. So in general, the recommendation adopts global evidence, but for the local and considered all the culture and epidemiological, risk factor that we are facing in our region.
Thanks very much. So coming to the Italian guidelines, Amelia, what do they say?
Yes, our recommendations have the aim of integrating B cells depleting therapies, complement inhibitors, FC neonatal receptor inhibitors in the general management of myasthenia gravis, and its use in persistent active or refractory disease or in patients intolerance of suppression of with severe adverse events. Of course, therapy escalation must be guided by disease severity and treatment choices by antibody profile, as we know, that by the disease pattern. One thing is to treat a chronic, even progressive disease, or a disease with very frequent severe relapses, but also by patients' characteristics like age and comorbidities. The treatment goal that we stated in the recommendations was to restore patients' quality of life to normal. That will correspond to an MGFA post-intervention status of minimal manifestation, also including pharmacological remission and complete stable remission with no or mild treatment-related adverse events. We also thought it was very important to prevent, since the start of therapy, treatment-related adverse events. So we also proposed a structured vaccination strategy and consider an important aim of these recommendations to reduce patients' exposure to long-term steroid treatment. Of course, the recommendations are based on the results of randomized controlled trials, but also to some extent, we also included some evidence from real world studies. And we recommended that the clinical course is assessed with validated outcome measure to guide treatment escalation or switching. And a very important part of our new recommendations is safety and comorbidity management.
Yeah, thanks. So I guess my interim takeaways for the guidelines would be all of them are very open and actively integrating the novel therapies, particularly considering them in certain situations and to consider them to control the disease. Best possible disease control from the earliest time points is a common theme, I would say. The other thing is a patient-centered goaling, using scores that are treatment aims such as minimal manifestation. And maybe to summarize, in my opinion, most important common recommendations is that we want to have rapid, sustained disease control, trying to implement more structured treatment pathways. One aspect, I guess, can be found in many, and I think all of the guidelines nowadays, is steroid-sparing strategies, and also the proper adaptation of biological choices without throwing away everything we had to manage patients that would be manageable also without biologicals. I guess all of the guidelines are currently integrating the novel evidences, which we now fortunately have, new evidence-based trials that are leading to approval of the therapies. But the guidelines are all based on consensus strategies, and there is not more to be said, I think. And we're coming in the end of the activity maybe to what do we need, what evidences do we need to improve this level of consensus or recommendations. So maybe coming to the next part of the activity is how do we apply those guidelines? So what we now could do is to think about clinical scenarios and how would those be managed in different countries, achieving the mentioned patient-centered goals. And I would like to start with a rather common scenario, a newly generalized acetylcholine receptor positive myasthenia gravis that is showing up with a rather high clinical score measured as MG-ADL, myasthenia gravis activity of daily living, and definitely also having heavy fluctuations in the previous years, also having 2 or 3 crisis-like or crisis-type exacerbations. So Niels, how would the Nordic guidelines deal here?
So we would of course start early active immunosuppression. We are actively doing thymectomies. We in the Nordic guidelines say within 4 months from diagnosis in those where thymectomy is indicated. We would start immunosuppressive drug therapies, and we have 2 alternative first strategies, either combination of corticosteroids and azathioprine, or rituximab as an alternative first-line treatment, influenced by the Swedish control study, which showed a positive result for rituximab in early after the diagnosis. So that would be our immunosuppressive drug treatment, and because we would start relatively high steroid doses, but then rapidly reduce them as low as possible, continuing with other first-line therapies. Azathioprine would be our first choice, or alternative second-line drugs.
Yeah, yeah. So, I mean, to add what the German guidelines would allow or say in such a situation is, does this patient adequately fulfill criteria of being active, highly active, or refractory? And we operationalized the criteria that are either built on MGFA level or criteria such as number of previous treatments or things, and I think this is the most relevant innovation, that a patient has for a certain period of time affection of daily symptoms of living. That means not really properly controlled. And that would be patients qualifying for introducing novel agents, such as fast onset immune therapies, either C5 inhibitors or FcRn modulators. Also at the same level of evidence by the time was also CD20 therapies. And the threshold to differentiate is that the patient is not anymore mild moderate, is an active patient. And once the patient is active, the patient should be then also treated more actively. I guess that is, I think, what the guidelines have most prominently introduced. How would Middle East deal with this?
I don't think it's significantly different than the international guideline. We emphasize the importance of starting acetylcholinesterase inhibitor, steroid, and steroid-sparing agent from the beginning. However, with clear, objective, and patient-reported outcome within 3 to 6 months, if no clear improvement or there's clear intolerable side effect, to immediately switch to more targeted therapy. So this is mainly, the approach in such patients.
Yeah. Amelia, anything to add
Yes.
from the Italian point of view?
Yes, we'll start conventional immunosuppression, steroids, and sometimes in association with immunosuppressants if the patient has a high risk of side effects from steroids, perhaps in association with emergency therapy if needed. And if in a few months or so the patients do not satisfactorily improved with this strategy, he qualifies for, for starting targeted therapies, both complement inhibitors or Fc ionata receptor blockers, as add-on therapy with conventional immunosuppression. For refractory patients, they are qualified to start new targeted therapies immediately.
So I guess the field of generalized acetylcholine receptor positive myasthenia has seen most changes and most, let's say, renovations of the guideline formulations and what we are able to do based on now new labels that are approved. Let's move now to the other category, MuSK, positive myasthenia gravis. We do have partially novel treatments, but how have the guidelines developed since then? So has there been so much changes in Middle East guidelines, Ali?
Well, in MuSK, it's very clear, and it's a bit, there was, almost, a consensus that, rituximab is the first line therapy. We have a very good experience with the safety of the drug, and it works, very well. So you can see in the guidelines initiation of rituximab from early on, or even, as a first line therapy to get, the fastest control of the patient's symptoms is the way to go.
Niels?
No, it's exactly the same. We would use rituximab. We are used to rituximab use for both for myasthenia and for other immune disorders.
Amelia?
Yes, of course, I agree. Rituximab is the best treatment for MuSK and G. Although a short course of steroids can be very much effective in some patients with MuSK antibodies.
I have to say the German guidelines are not different here. On the other hand, I would like to ask the group, is there something written or done to be done in terms of options that go above and beyond rituximab? So is there a role for the fast onset immune therapies in myasthenia? Niels?
Myasthenia is very rare in the Nordic countries, and these new treatments, due to cost-benefit restrictions, they are not really available or very difficult to use from cost-benefit reasons. So I guess that these treatments would act, but in our few patients, rituximab has worked very well.
Ali?
Well, I think there is maybe not in the GCC guidelines, but emerging evidence now that FCR inhibitor, might be also a very good option in these patients.
Anything to add, Amelia?
So I agree that the inhibitors of the afcinium receptor are very effective in MuSK-MG, confirming the very, the very good response to plasmic change in these patients. And also, perhaps they respond very well and may overcome all the difficulty and the side effects possibly linked to plasmic change in during a severe disease deterioration. These patients are quite frequent.
Yeah. Thank you. So we have a third scenario that in the German guidelines is not really flagged in the general approach as a distinct, let's say, patient scenario, which is refractory acetylcholine receptor MG. Many colleagues might remember that the first real biological that entered the space, eculizumab, was based on this specific category of patients. It was approved for refractory MG. On the other hand, we often summarize various types under refractory, and we call it highly active, including refractory, and we often see it simply as more difficult to treat. It's not really in a pathobiological, immunological sense refractory, and therefore for the German-speaking guidelines, the approach is not really different, except for you might also then have to consider certain experimental therapies, including CAR-T, even HSCT. So this is frustrating cases, very, very, very niche cases. Anything different that you would see, Amelia?
Actually, I don't see much differences because also in Italy and in other European countries, patients who are not significantly improved by immunosuppressive therapy are candidates to targeted therapy, as I said before, in add-on to conventional therapy. But otherwise, the access to targeted therapy is pretty much the same.
Niels, Ali?
Yes, I think that with the new treatments, it has been an increased focus on active treatment of myasthenia gravis in general, and there are several immunosuppressive drugs, more traditional drugs, that should be tried. It's a question about doses. You can try high doses, so you should also use traditional treatments. For the really difficult to treat ones, we in the Nordic countries, it has been undertaken stem cell transplantation in a few patients. Sweden have transplanted a few patients. There are several case reports, small series, showing a positive effect of stem cell transplantation. So there are alternatives, and of course the FcRn blockers, complement inhibitors are very they are the drugs trying for such patients.
Yeah, well, I totally agree with all what have been said. Targeted therapy is easy here to, there's clear room for the targeted therapy. I would add just one thing. It's not unusual in our region to use chronic IVIG or rituximab in these cases. And we saw some patients responding very well to either rituximab or chronic IVIG.
Let's actually round up this part with a short statement on certainly those guidelines are not just about immune therapy. They are also in other types of therapy and support. Is there anything to be said beyond the, let's say, very important aspect of novel or traditional classical immune therapies? Maybe Niels?
Yes, in treatment of individual patients, you should of course listen to the patient, and they are also focusing on social aspects, a wider number of symptoms, comorbidities, things like that. They are not perhaps so important in a guideline, but you should remember these aspects in individual treatment. And the Nordic guidelines had a strong representation of patient representatives, and they were very aware of these aspects, and I wish that we as neurologists also remember and focus and take an active part regarding these aspects.
Ali?
Well, in my opinion, patient-centered care extend beyond muscle strength, and we should be looking to patient, activity of daily living, their ability to go to work, take care of their family, plan, pregnancy safely. In the GCC guidelines, there's also an emphasis on special, cultural issues in our region, like, fasting, culture, consideration, family, support. So I think, you know, uh, looking to all those aspects is very important. It's not acceptable anymore to just measure, the patient's strength and say, well, they are very well controlled.
Yeah, absolutely. Amelia?
Yes, in our more recent guidelines, there is a strong emphasis on safety and prevention of treatment-related adverse events. These events have been known for many decades. They now can be prevented quite effectively. So this is very important for patients and is real very good clinical practice. And we don't have to forget that our population is more and more made of elderly people, and elderly people have a lot of comorbidities. So prevention of the side effects is really very important.
Yeah, thanks. That were all very relevant aspects. I should add that particularly a statement that comes to mind that we position prominently is we should aim at best possible disease control, but preserving best possible quality of life without harming the patient. And I mean, this integrates everything that has been said. So it's not just about the doabilities of modern immune therapies. They have to be safely, but properly and adequately introduced. So guidelines are a continuous process, also have to be updated because of novel therapies. Maybe a final statement by each of you. What would you like your local guidelines should include, and they are currently lacking exactly this? Maybe starting with Amelia in Italy.
Yes, I would like a very good real life study, possibly prospective, if no randomized, at least prospective comparative studies, because we have very effective agents, very effective therapies. We know that they act very quickly. We also must know as they work in the long term in a real life population. And I think that this data results from these studies will be very relevant for our clinical practice.
Thanks. Niels?
We are categorizing our patients into subgroups. Most guidelines concentrate on some subgroups, those with antibodies with certain age spans. For example, what about children? What about the very old ones? What about ocular myasthenia, which is an important topic, not usually included in the guidelines? and also with comorbidities. We need to probably to try to be more specific in defining several myasthenia gravis groups also in our guidelines.
I'm hoping that we can see a living guidelines rather than a static publication that we revisit every few years, using the advantage of digital registry and patient-reported outcome, where you can modify and customize the treatment accordingly. So I believe that no size, not one size fits all. So those patients, every patient is a different patient. So if we can have that dynamic guidelines that can adapt all these changes immediately, I would that's what my dream would be.
We indeed do have that in Germany. It's indeed called Living Guideline, and we are expected to update once yearly under the same, let's say, formal approved structure. And 1 year is a fast pace rather, but this is exactly coping with the problem that there is so much happening. I mean, for some disciplines in neurology, you don't really need living guidelines, but for myasthenia, you clearly need it. My wish would be, and that is also now planned for the update of the German guidelines that will happen in 2026, is I call it deconvolution of complexity. I mean, we're talking about very complex situations of different treatments. And the other is better information about optimal treatment sequences. So both are things that we have to make up our mind. I mean, we have more and more availabilities and possibilities, but do they all make sense, or should we not stratify better? So let's come to an end. I conclude this very informative and educational activity in saying that due to advances in treatment, particularly biological novel treatments, there is a move toward a more proactive management in MG, and I think this is a very, very broad consensus. All guidelines aim for minimal symptoms, they aim for good quality of life, they aim for steroid reduction, and they also flag the point of keeping patients safe. There are, however, some variations in different country-specific formulation, how the country-specific possibilities are or necessities are, how tightly they tie decisions to validated scores, and how explicitly they integrate life context into routine MG management. But the general trend is that MG is a treatable disease, which should be also treated to the best possibilities. So we're not accepting symptoms or fluctuations to the same extent we did many years ago, where we had to accept it because we didn't have those possibilities. Niels, Amelia, Ali, thank you for this absolutely great discussion, and I thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.